So with this robust timeline, we are going to hand it over to our first group. We've got Ms. Kathy Johnson, Mr. Walker. They're going to be joining us for our survey and overdose monitoring subcommittee. I know they've been working hard, and so Kathy, take it away.
Superintendents and principals might be more of a receptive mode to do that, when schools actually might be so detrimental doing it over the summer.
Yes, thank you for mentioning that. That is actually a suggestion that came from some of our schools, which is that if we offer the survey prior to the new school year, 24-25, those administrators might have an opportunity to really focus on that for just a bit, you know, before they hit the ground running, so to speak, once the school year begins. So that's exactly why we followed through with that suggestion, and we decided to offer it in July.
So we've kind of broken down our limitations into 3 different categories here. So we have our survey distribution, the obvious time constraints, and then the actual survey responses themselves. So first off, with distribution, as a group, we really met on this and tried to figure out what's the best way to do this. Do we want to send surveys to students, to teachers, to administrators? And what we settled on, and thanks to one of our committee members, Tim Brienza, we decided that sending to superintendents and having them disseminate the survey to the principals and other high administrators they felt would best serve the role of answering the survey would be our best bet. It reduces the points of contact that we have to send out to, and it makes it to where, you know, somebody who has more authority over those individuals and who they recognize can ask them to complete this for us. Obviously, we've picked July 15th to roll out our survey, and we have a 6-week window there. And, you know, the reason for this is time is of the essence. We really want to deliver the information and the data so that our other subcommittees can use those responses to help formulate whatever they're doing in helping to stop fentanyl overdoses. And so it was really important for us to try and make this happen as soon as possible. And that is in no small part due to the starter survey that Dr. Geyer graciously provided us. And we have been using that to try and formulate the overall survey we'll be sending out on that date. Now, one thing we may come into or have as a problem is the low response rates, and that's just due to the timing of the release. As I'm sure you're all aware, it is summer, schools are out for the summer, and a lot of people will end up, you know, going on vacation, maybe taking a break from work or something like that, and so we want to recognize that. This 6-week response window is to allow those schools that are going to be coming back into session to have a bit of time to settle down, but also so that we can have the you know, administrators kind of send it out. We talked about a July 1st date, but determined that that was a bit too soon and was more likely to have individuals who may not be able to complete the survey at that time. Moving on to time constraints, again, that kind of falls into that same thing. 6 weeks is a lot of time to complete a survey, but really it's about the maximum amount of time that we can give to people if we want to be able to get this done. Because the other part of this is that with a survey, you have a lot of data analysis. You know, if we give somebody a free response question where they can write whatever they want, we have to go through and determine what does that mean, how do we approach this, how do we look at that from a data perspective. And when on a conservative estimate, we're looking at 500 plus responses, that's a lot of time and effort to try and go through that. And so we really wanted to bring that into light and understand that that's something we'll have to address. And then moving on to the survey responses themselves. Because of our time constraints, we are going to have to simplify responses to the survey. Ideally, you would have people be able to write you an essay on everything they think is wrong or something they view as a problem or as possible solutions, and we could analyze that. But we just don't have the manpower, and that's way too much data for any group of people to look through. And so we have to acknowledge that by doing multiple choice questions, which I'm sure all of you remember from your time in school. And they don't capture as much as we would like, but they do give us a good idea as to some of the things there. And coupled with certain free response questions, we really hope that this is going to allow us to get a good grasp on the state of the state so that we can provide the rest of you with the information that you want for your subcommittee purposes. Next, please. So moving on, we have solutions to these. We are working towards them. Not all of them are the prettiest solutions, but they are what we have determined is probably our best case scenario. So when we're looking at survey distribution, Best case scenario there is we're going to send out a lot of reminders to people. We're going to ask them repeatedly and remind them that this is for the next generation. This is to reduce deaths that are unnecessary among Arizonans, and try and help them to recognize that just completing this short 15-minute survey is really going to help inform policy moving forward. And so, again, that 6-week response window is a solution that we have to this time frame. On top of that, we really want to provide resources to all of these schools, because the stigma of, acknowledging that your school may have issues with addressing overdoses and things like that is really important. And so we're going to try and increase the time frame and acknowledge that, hey, by completing this survey, you're helping us get these resources out sooner. You're helping us solve this problem faster. Moving on to the time constraints aspect of things, we really want to have timely responses, and we want to have informed resources for everyone involved. And so again, sending out reminders to people, it's tried and true, and it works. We also want to make sure that our surveys aren't bloated. It's really easy to want to include all kinds of different things in a survey, and so our goal has been to try and reduce the amount of questions just so nobody feels overloaded or overburdened by the actual surveys themselves. And so we're working to make sure that our questions are streamlined, efficient, and they inform on what we want them to inform on. And when we get to those survey responses themselves, there are a lot of planned responses. Ideally, we would have every single school in the state responding to this. And that's a lot of data. And so we really want to try and remind these individuals that they can respond to this survey and it will be confidential. This is not a reflection on their administration or their skills or even what's going on in their school. We don't want to make this seem like they're going to get punished if they're honest about the problems that are going on relating to opioid overdose and fentanyl in their schools. And so this is our solution to try and help with that, is reminding them that, hey, this is going to be anonymous. You don't have to worry about this. And then finally, we have our deliverables. By the next meeting, we're going to have our survey done and possibly even sent out. So that's pretty big on our part. We're also, based on the timeline, likely going to have some preliminary responses. Not going to make any conclusions based on that, but just give a rundown of, hey, this is how many responses we've received. This is the type of thing we might be seeing, just so that the rest of you can have an insight as to what's going on with this survey. On top of that, we're not just the survey subcommittee. We are the monitoring subcommittee as well. We've been focusing on the survey because time is of the essence there, but we really want to work on that monitoring draft form that Dr. Guy provided to us and try and set it up in a way that we can have an informed and reasonable way for people to report all of the overdoses that may be happening and look for those solutions in that regard. So we're going to be working on that monitoring form as well, and possibly looking to other solutions for schools to report any overdoses and things of that nature. And then we'll also have a preliminary code book. If you don't know what a code book is, basically when you have the free response questions, you need to be able to categorize them in some way. And so that's how you do it. You have basically categories, definitions of the categories, examples, and things like that. So we should be able to provide you with that to give the rest of you a better idea as to what exactly we're looking for in the data. If you have any suggestions or ideas or things you want to know from the survey, please, by all means, message us, email us. We want to include the rest of you because it is a group effort here. And finally, thanks to all of the partners in our subcommittee. They're great. They've really helped us inform this and make it to a very successful survey subcommittee and monitoring subcommittee so far.
Gary Kirklis. I'm a Phoenix area pediatrician. I'll be speaking on behalf of myself and the American Academy of Pediatrics and the policy subcommittee. Next slide, please. So sort of an overview of our mission is that we are here to create policy language, specifically to create policy language that would address the opioid epidemic within schools, and to create verbiage to have naloxone in schools, either as a legislative approach or more preferably as simply a protocol policy within the Department of Health and the Department of Education. Next slide. Specifically to achieve that goal, we have four subset of goals. I'll be speaking about the first two. So the first one is to collect and review school district policies currently in place in Arizona, essentially to see what we have to work with, what's currently available, as well as to look at what sort of legislation we have available that would support support our initiative, as well as to review what other states are doing as well. We also are going to amend the DHS emergency guideline for schools in regard to poisoning, as well as review policies with ADE and DHS to ensure no conflicts, but I'll be speaking on the first two goals today. Next slide. So those are the first two that we will review. Next slide, please. So quickly, just this, I guess it didn't really fit well into the PowerPoint, but these are the current laws that we have on state, so the ARS revised statutes. So the first one there, 15.334, 341, essentially basically saying that Arizona's public schools do have to have a policy in state. Now, when we read this, we didn't know how to interpret this. Does this mean that they have to have a policy in states for the delivery and carrying and the procurement of naloxone in schools, or is this just to have a policy regarding it, and if their policy is not to have a policy, then that would suffice. And then next is ARS 362267. This essentially is a Good Samaritan protection for anyone who is delivering naloxone within schools, that they wouldn't be held liable if that medication was not delivered in the right way. So more basically Arizona Good Samaritan law. And then on the very bottom, again, I'm sorry that this was not didn't fit properly in the PowerPoint, is essentially reporting. So currently, peace officers, medical personnel are required to report the use of it. However, schools are not included in that legislative bill. Next slide, please. So when reviewing, so that's what we have to start off with. That's what currently is the law of the land in Arizona. And then as far as policy within schools, we use the Arizona School Board Association website. It's a really great website. You can go to every school district in Arizona, see what policy they have in place. Now, we don't know the utility of this quite so much. Most schools will have something like this that I highlighted, which essentially is a cut and paste version of what the ARS basically stands, is that the school district needs to have something in place regarding a policy regarding naloxone. And then the next slide over would be some schools, particularly high schools, will include the Good Samaritan ARS 362267 or 2266. But we don't know if there's any, this is what is forward-facing in public. We don't know if schools actually have another policy that perhaps is more detailed, but this is what we could find from our research. Number two, review legislative policies in other states. So in other states, most of the time, their legislative mandates will say something that says school boards may have a policy in place regarding naloxone. So giving every school board the opportunity to do so. And I highlighted the word may. The only exception to this, next slide, would be in Washington, which they interestingly have a must. So school districts with 2,000 or more students must obtain it or maintain at least one set of opioid overdose reversal medications in each of its high schools. So this is sort of the outlier as far as legislative. So again, back to our goal to produce policy language that schools can adopt statewide. We also looked into what the Arizona Department of Health already has in place. So they already have a standing order for the procurement of naloxone. And so this is something that's already in place. School districts are using this in order to obtain naloxone from a pharmacy as a standing order. Any school district doesn't need to reach out to a pediatrician or any other medical provider. They can already use the DHS standing order to obtain it. Now, when we look at this, we don't know perhaps if school districts know that this is enough for them to procure their naloxone and to administer it within their schools, or if school districts would perhaps feel more comfortable if that standing order also had something about the delivery of it. Now, with that standing order plus the legislative bills that we already have in place, the ARS would allow school districts to use it because we have the ability to, we have the laws allow us to use it and to obtain it. But perhaps school districts would feel more comfortable if that standing order also include verbiage regarding administering it. Second, or actually, if we can go back one. We also have a policy and protocol for the delivery of epinephrine, so an EpiPen. In the event a student were to consume a peanut butter jelly sandwich and didn't know they had a peanut allergy, and would have an anaphylactic reaction, we already have laws and policies in place, of which DHS has been a part of for the obtainment of the epinephrine and the delivery of it in schools. So we thought this would be a really good model for naloxone, because it's very similar. We have a poisoning or an anaphylactic reaction in a school. We need emergency intervention, and this would be a good model. Next slide. So this is just a picture of the standing order for naloxone by DHS. They can either obtain it through the intranasal, which is probably the more preferable, or the intramuscular version. But as you can see, this is what a school district could use to obtain the naloxone from a pharmacy. No verbiage in it as far as administering it, but potentially this is a next step for us to include verbiage for the delivery of it. Next slide. And here is the protocol for epinephrine in schools. As you can see on this slide, there's annual training that goes a part of it. Next slide. And the protocol for the administration of it. So again, this would serve as a model for policy for schools. Next slide. So next steps. So we will be working on a standing order to administer language, and we're working with DHS on that, and then also to create a draft of naloxone policy and protocol based on the epinephrine policy and protocol for DHS and ADA for their consideration. We would work on a draft language, provide to both of them, and then they can use it for their consideration, much similar as they have done with epinephrine. And then we're also going to speak with the Attorney General on legal implications of this to make sure all our ducks are in order. And that's all I have.
Hello, everybody. I'm Dr. Crystal Renzel. I am an academic hospitalist at Mayo Clinic, and I am the chair of the Student and Staff Training Subcommittee. And I have two vice chairs, Kevin Mack and then Samantha Reeves from the Arizona Department of Education, who are assisting with this very important subcommittee. I think the discussion that we just started to have before I come up to speak was really leading into this particular subcommittee and the depth of the difficulty of disseminating all of this information to all of the students and staff that work within Arizona Public Schools. So first slide. So we, as a subcommittee, came up with some goals and objectives before we started. We've met twice thus far. And our first is to create a standardized staff, parent, and student training on opioid awareness and opioid overdose and reversal. So going directly to what we were just talking about, utilizing existing best practices and expertise, and we're going to go into that in a minute. We're going to disseminate the curriculum to all public schools in Arizona, and then Heraclean task is develop metrics to track the success of the curriculum. So as all the subcommittees will discuss, since the scope of this project is so large, having trackable metrics is going to be very important. Next slide. So just a little review as to who's on our subcommittee, just so everybody understands what a variety of people we have. So on the subcommittee, we have physicians, counselors, we have a pharmacist, we have local school administrators, leaders, we have teachers, we have social workers, public health officials, educators, drug intelligence officers, parents, and students. So we are trying to capture everybody who would be on what we like to call the sharp end of this stick. So the person, like the student, who finds somebody down and suspects an overdose, all the way to the blunt end of the stick, which are the administrators who are going to be developing the policy. And the reason for this is that we really want this training to be very facile, meaning we want it to be able to keep up with the time. So as things change, we want the ability of this curriculum to be able to change with it. And we don't want it to be static. And I think that's one of the hardest things about this subcommittee, is trying to find a curriculum that can be updated and that can have the most up-to-date information. Next slide. So the other subcommittees have sort of already gone through this, but just so that everybody understands the scope of this, ADE itself supports our 15 counties and more than 200 public schools, which was already mentioned in another talk, and over 400 charter schools with 14 career and technical education districts. What does this amount to? 1.1 million students. That's how big this problem is. It's bigger than this, of course, because it's nationwide, but that's how many students in Arizona that are being impacted. As of its state right now, we know that education on opioids, fentanyl in particular, addiction, overdose prevention, and reversal is not required to be taught in public schools. Thus, there's no standardized student, staff, or parent curriculum that currently exists. multiple organizations, and this is not to take away from organizations that have come in and done homegrown curriculum, because there are quite a few, and we're going to talk about those in a minute, but they have come into schools and implemented curriculum. But as of right now, there's nothing coming down as a standardized curriculum from the state that's endorsed by the state of Arizona. As you all know, unfortunately, Arizona is the largest trafficker of fentanyl across the Mexico and US border. Most of the time, overdoses are happening and the student doesn't even know that they're taking fentanyl. And you guys all know that that's coming from counterfeit pills. We know that opioids are in Arizona, and we know that students are being harmed, and we know that we have vastly underestimated the number of students that are being harmed by opioid overdose. And because of this, we know that there's no standardized reporting structure of the number of fatal and non-fatal, which are just as important, overdoses that have occurred in Arizona schools. As Dr. Geyer alluded to earlier, school districts have come forward and said, I've got 3 or 4 here, 3 or 4 here. Well, we've got 1.1 million students, so if you add that up, the number is huge, I bet. It's a lot larger than we think. So the depth of the problem is unknown, and it's really hard to enter something in the state of an unknown. So I think that the survey group is going to be really important for us to understand, especially in the staff training education space, what's the current state, so we can get a better understanding from them how we can best build a curriculum. Next slide. So as I said, we talked about how there's really no standardized curriculum, but also, as we've learned a lot from our student, who's been really important on our committee, there's really not much awareness, and this is something that she mentioned in the first subcommittee meeting, of the opioid crisis, unless people have personal experience. So those of us who've lived through it, watched it, taken care of patients who have overdosed, then we've seen it and we know the depth. But a lot of times people don't actually realize what the problem is and how difficult it is to treat. And because of that, then we don't have a recognition of the signs and symptoms. So you may see somebody who you think is on drugs or is on the verge of overdose, but you're not sure. And what's your liability? And we kind of talked about that in terms of the Good Samaritan for the previous presentation. Also, what's been discussed in the previous 2 subcommittee presentations is this stigma associated with opioids. So we know that this is what makes the discussions challenging, and this is what makes implementing curriculum challenging. Lack of funding for programming is always going to exist. So that's something that we're just going to have to figure out how we're going to work around and figure out how we're going to do that so that we can have standardized curriculum. And again, as we mentioned, there's a large number of schools with varying resources and technology. So we all believe we have access to Wi-Fi and online, but I'm learning slowly that that might not be the case across the state of Arizona. So this came out of our first subcommittee meeting. So the first subcommittee meeting was really to say, what I just said was, let's analyze our current state and find out what we need for a curriculum before we actually look at curriculum. So what we decided is we need succinct and age and culturally appropriate, because we know there are a lot of different cultural groups that exist in Arizona that have a strong presence. Scope to grades 6 through 12, inclusive of parents, students, and staff alike. Alignment with current curriculum, perhaps part of the physical education training that's already being provided to students. Both online and in-person training, and again, in-person training is going to be difficult given the depth of the problem. And a modular format that can be trackable. So these are some of the process measures that we came through to say, hey, is this actually working, and how do we know if it's working or not? So what we want to do is increase the number of students who receive opioid recognition, overdose, and reversal education, increase the availability of naloxone per student in school, and increase the number of school and staff trained in opioid and naloxone education, and I'll add students to that list as well. The overall outcome that we all want to do is to decrease the number of non-fatal and fatal overdoses among students between grades 6 through 12 in Arizona public schools. I think we all can agree that that's the overall goal of this subcommittee and this entire Stop It committee task force. So now the committee met on Friday, the 21st, and we are currently exploring a lot of different curriculums. So you guys can see the list of curriculum here. We have met with 2 large groups. Now these groups, the Sold Out Youth Foundation and the NFL Alumni / Village Paths, they are national curriculum. Natural High, also a national curriculum. And then we have some other local curriculum that we're going to be exploring as well. We have local curriculum that's delivered by a group called Community Bridges. We have another national curriculum that's provided by the Drug Enforcement Administration called Operation Prevention. And then we have our Arizona-specific curriculum that's among the SAC-LAZ, which comprised of HEAL, the Tanner Community Development Group, and Song for Charlie. We have their curriculum, and we'll be reviewing that at the next meeting. And finally, what we found going through all of these curriculum is that gap in curriculum is what we've been discussing, which is naloxone overdose recognition, or naloxone administration, sorry, not overdose. So naloxone administration education. So that's one of the things that is a gap that actually really doesn't exist or is not really fleshed out in a lot of these other curriculum. And so we're looking at curriculum that's been provided by Samantha Reeves from nursing staff at Banner Health, U of A, and then Access. And some of these curriculum are actually not created just yet. These groups are in process of creating those curriculum. This is going to be hard to project, but basically what is happening in the background is when we are having these groups present, we are using a rubric to figure out if these curriculum check all of the boxes that we would like. And it is trackable, and that we can actually use this curriculum and modify it in order to meet our needs for our students and staff in Arizona. So with all of the groups that are coming, we're going to be doing this as a subcommittee and then submitting our results to the bigger Stop It task force to be able to pick which curriculum or a blend of curriculum that we think might work for our state. The other option, after reviewing all of the curriculum, is to develop some of our own curriculum, potentially using existing learning management systems. So suffice to say that reviewing all of the curriculum, there will be pros and cons to that, and then we will make a determination of what can we blend, what can we modify to suit our needs as a state. So we have our next meeting will be in July, and we already have curriculum lined up that we're going to be reviewing during that meeting. Again, like I said, we're going to be reviewing those pros and cons. And I talked about developing a curriculum that can be delivered what we call just in time, which basically means that when you need it, just as much as you need and in that time frame. And we'll test the curriculum prior to delivery with select students, staff, and parents. So what do we need from other subcommittees? Because this subcommittee is really dependent on other subcommittees, maybe more so than all the other subcommittees just because of the depth of this endeavor. We need the current state analysis from the survey because there are a lot of education questions that go along to those process measures that I don't have baseline metrics for. We also need information on naloxone in schools, so that way we can develop an appropriate training that's scoped. And that will also come from the survey and also come from the policy subcommittee as to what's decided to be inside your policy. Next slide. So that's all I have for you today. I want to thank you all